Good morning, and welcome to each and every one of you here in person as well as listening to the live stream of this grand rounds at Houston Methodist Hospital. Before I introduce our eminent speaker for today, I wanted to go over some housekeeping items. So number one, we will be passing around a microphone to ask your questions. As you all know, we are broadcasting this live worldwide via Vimeo as well as YouTube. The recording is always available for viewing later on. Please comment, subscribe, and share our YouTube channel. For our viewers who would like to submit a question, text DeBakey, capital D-E, capital B-A-K-E-Y, and the number is 37607. It gives me a lot of pleasure of introducing Dr. Farouc Jaffer, who is visiting us from Boston. His bio data is so amazing that I don't even know where to start. But to summarize, Dr. Jaffer did his undergrad on the West Coast at Stanford, and then wanted to move east, and has been then did his med school at, was it UPenn? Yeah, UPenn, and then decided to move to Boston, and he's been there ever since, and has done his fellowships at Mass General. But not only that, he was not satisfied, so he did postdoctoral fellowship, research fellowship with molecular imaging, again at MGH. And ever since then has been a faculty member and an interventional cardiologist at Mass General, and is an associate professor of medicine at Harvard Medical School. Dr. Jaffer's main interest of research is actually translational molecular imaging approaches to investigate inflammation and vascular biology in living subjects. And that is going to be our hope to learn from him today, as this field continues to evolve and is one of the most interesting fields today. His lab has partnered with leading engineering groups to develop translatable intravascular NIRF, or near-infrared fluorescence, molecular imaging approaches, and has performed first-in-human studies of intracoronary OCT and NIRF imaging of CAD. He also has done a lot of work in venous thrombosis, obviously has published extensively, and also is a recipient of an R01 grant from NIH. I know him as a CTO operator. He is the director of coronary interventions at Mass General, and my first interactions with Dr. Jaffer was in the CTO world. But what stood out from day one, every time I would go to the meetings and listen to his lectures, he would do something unique. He would start integrating imaging to his CTO work. And I've never actually had an interventional cardiologist do that before. So he's at the forefront of integrating coronary CTAs and bringing it to the cath lab. And he has actually published a lot on that and taught us a lot on that. And ever since then, he continues to build on this and has now become a lead investigator in applications of fluorescence imaging into the CT and bringing that to the cath lab. So without further ado, it is my pleasure and honor to invite Dr. Jaffer for our grand rounds today. Farouc?
Good morning. Thank you so much. What a lovely introduction. It's great to be here, great to be with you. Thank you for coming in the morning. Thank you for the invitation, and always just awe-inspiring to be in the medical center area here. It's really a thriving, remarkable place. So I'm delighted to share some of our work regarding fluorescence molecular imaging. Fluorescence is probably a concept that people have been exposed to. There are really two parts to this talk. One is on the development of fluorescence and how it might be used in the coronary arteries for intracoronary imaging. And then the second part will be, as Alpesh mentioned, to understand the role of maybe CT in guiding more complex coronary interventions. My disclosures here. And so our outline for today is on these two areas, both with fluorescence molecular imaging, and we'll go through a number of different applications, starting first with the foundations of how we developed this field and why it was an unmet need that really has potential to change what we do in the cath lab. And the second part is going to be on CT and its applications in CTO PCI. So this audience definitely knows we have this issue with coronary disease progression that is not yet well resolved by standard imaging. Our ability to predict plaques that are going to progress have really been attempted to be best understood by intracoronary imaging and now more so with CT in recent years. But despite our best prediction capabilities with structural-based imaging such as IVUS or OCT or even CT, our positive predictive value, especially on a lesion level, is limited. That is, really 20% of patients that have high-risk plaques will go on to have an event within 3 years. That limited predictive value limits our ability to counsel patients and say, well, it might be actually reasonable to consider intervention. We need a positive predictive value that's going to be higher, 50, 60, 70%. I think when you tell your patients that 2 out of 3 times they're going to have an event in 3 years, many patients are going to be open to the concept of randomizing themselves in trials for preventative intervention. One of the areas that we haven't been able to really assess in human coronaries is inflammation and coronary pathobiology. We cannot do that currently. The field of molecular imaging aims to do that across a wide variety of diseases, most developed in cancer. And in cancer, of course, we have the ability to also biopsy, to personalize medical therapy based on receptors and proteins. We design chemotherapy regimens because we know the pathology. We do not know that. And coronary artery disease has a range of pathologies really driven by diversity of inflammation, oxidative stress, and calcification. We need to really understand these components to best personalize medical therapy. The way that molecular imaging works, very simply, is to take an intravenous injection of an imaging agent, have it target to its desired area, in this case the coronary arteries, and then detect that with a dedicated device, such as a catheter, for example, in the coronaries. For other parts of the vascular system, non-invasive imaging through FDG PET is probably the number one approach now, sodium fluoride in many centers that can do that. So how are we going to image coronary plaque inflammation? Well, just before we do that, just to reinforce the importance of why we need to detect inflammation, multiple studies now have shown, and seminal work from Paul Ridker really demonstrating that after PCI, the amount of systemic inflammation in the blood tells us what the event rates are going to be. So even if LDLs are optimally controlled under 70, if there's an elevated hsCRP in the blood, there's a higher risk of events. This has also been recapitulated with measurements of cathepsin S in the blood after non-STEMI. Cathepsin is a cysteine protease that is involved with plaque progression and fibrous cap destabilization. In patients that have higher systemic levels of cathepsin S, they have a much higher event rate after non-STEMI. This suggesting that inflammation is driving ongoing plaque progression and disruption. I would submit, though, I think we can do better than a blood value. We would not screen for breast cancer with a blood test. We would image the breast, and we need to do a better job using imaging to more precisely assess whether or not coronary plaques are inflamed. We have some emerging tools for imaging inflammation, but they're really indirect. We talked about hsCRP. Perivascular adipose tissue is an interesting concept from CT. It's really measuring the fat around the vessel. It's not measuring the intima, which is where the actual disease process is. There's inferences from perivascular adventitial fat measurement. It's very interesting and some very compelling papers for prediction. But direct measurement, it's still an indirect measurement of what's actually going on in the atheroma itself. Sodium fluoride, another really interesting molecular imaging approach, measures osteogenesis, not directly measuring inflammation, has some also interesting applications, has not yet been the home run for prediction. So how did we get to fluorescence? Well, basically, we realized that, first of all, for molecular imaging, our targets for inflammation are really driven by the wealth of biology, both for plaque rupture and for erosion. This has been worked out in decades. And so we have key targets, macrophages, proteases, neutrophils, leakage from absent endothelium. We have ways that we can image these through imaging agents. So we had to choose. We had nuclear approaches, MR, ultrasound. And it turned out that optical-based imaging ends up being a very, very good approach for the cath lab. And that's because light is extremely easy to transmit down small fibers that we use for intracoronary imaging, for example, every day using optical coherence tomography or near-infrared spectroscopy. So doing other modalities such as catheter-based MRI or nuclear imaging is a much harder endeavor, and ultrasound is limited because of its limited sensitivity for molecular imaging agents. Fluorescence really has the sweet spot, and it's already in the cath lab. So we started to look at, well, can we actually start to do fluorescence-based work? It's a different property than near-infrared spectroscopy, which is absorbance, or different than OCT, which is based on backscatter. We started looking at fluorescence because imaging agents can be conjugated to a fluorophore. You can excite that fluorophore and then receive the fluorescence with catheter systems. The specific wavelength was a really important parameter to consider, and we ultimately recognized that the near-infrared window, which is about 650 to 900 nanometers, is really the best place to image because there's less attenuation through blood. It's a sweet spot, and there's less autofluorescence tissue background, especially as you get to 750 to 900. And so this was a big step forward, and we started working on developing imaging agents that were really readable in this area. And that's led to several clinical imaging agents, including indocyanine green, a new protease imaging agent called Lumisol 015, and others are emerging from the cancer world. Most of this field is being driven by cancer imaging, where surgeons will inject a molecular imaging agent before they operate. They'll put on fluorescence goggles. They'll have a ceiling camera for fluorescence. And when they have their fluorescence goggles on, they can see so many more microtumors that they can debulk. It's really changing the field, and there's many trials in the US and worldwide. Some of these imaging agents also have reactivity for coronary pathology, so there's going to be a range of imaging agents coming. We have worked on two systems to really realize this in patients. One is combining fluorescence with OCT, and the other one is combining fluorescence with IVUS. This is really a partnership with leading engineering centers across the world. Gary Turney is my partner at MGH, who's brought in, who was really the father of OCT clinically in the cath lab. A superb engineer. We worked together to develop a combined system that could do fluorescence and OCT together. So now we have structural and molecular imaging in a single catheter. And this is just a kind of a typical readout. This is a rabbit aorta showing the diversity of inflammation, which is pseudo-colored here in orange, overlying the grayscale anatomy. It's also possible to do this with IVUS. Both systems have applications. Both IVUS and OCT are used, of course, and both of them have the ability to be enhanced with fluorescence combination. This is a more complicated system to build. It requires a transducer in series with an optical fiber, and that is a more delicate process. Now it's allowing us to do work that allows us to detect fibrin deposition, for example, on stents, and maybe some interesting work on geographic miss, which I'll show some more later. One question might be, well, how do we actually do this? How would we actually do this translationally? And just before I get into the applications, I just want to set that in place. The world is really becoming an intravascular imaging place in the cath lab. It's increasing. While it's relatively low across the United States, the rates are rising, driven really by, I think, our younger interventionalists and trainees understanding that they just do a much better job of sizing and optimizing when image guidance is in place. And of course, stent expansion has been the number one driver of the use of IVUS and OCT. The way this would really work is the only difference between doing standard IVUS or standard OCT is to just inject an imaging agent before your final pullbacks. And at that point, you'll be able to image the target vessel that's been stented and the non-target culprit arteries to understand, is there plaque inflammation still in my artery? What is my risk going to be when I leave the cath lab? I should be able to tell a patient, you have a 10-year event rate, 10% event rate this year, or 5%. Maybe I should do something different medically. These are some of the concepts that we need to do better by personalizing that. And so this is kind of the standard. We're not going to be taking patients who are just coming from non-invasive imaging. They're going to be patients that are dedicated, already coming to the cath lab, already having PCI. It's the ability to now expand that imaging application to personalize imaging of the rest of the artery. So let's get into some of the applications. This is a number of just snapshots, and I'm happy to take questions at the end. There's some parts that are a little more technical, but I just want to make sure I convey the high-level applications of what fluorescence is really adding to structural imaging. So we talked about the role of cathepsins. This is an important protease that's involved in plaque pathogenesis, and from a molecular standpoint has been highly validated as an important contributor to plaque progression and disruption. It cleaves collagen and elastin, certain cathepsins, and that leads to fibrous cap disruption and positive remodeling plaque expansion. So we asked a question using our intravascular imaging system is, does fluorescence imaging of inflammation, does it actually predict plaque progression and really independent of structural measures? So our work has been largely preclinical until the last few years. And so you'll see a lot of this standard model in the rabbit, which uses an aortic atheroma. It's about the size of a human coronary, about 3.5 millimeters. These animals develop atherosclerosis rapidly that have inflammation in their plaques. These animals underwent serial imaging with serial IVUS and serial fluorescence OCT 4 weeks apart. They were injected with an imaging agent before each imaging session. And when we looked at the comparative data, this is a kind of a representative 2D fluorescence map, baseline imaging at 8 weeks, follow-up imaging at 12 weeks, 2D IVUS map, 8 and 12 weeks. These are the imaging intensities that are plotted as a function of the distance. The reason it's an eccentric plaque is we balloon injure in this area to augment atherosclerosis. It's a very standard model along with hyperlipidemia. What we found is that a single measure at baseline, this 8-week fluorescence measure, was really correlating to the change in plaque burden that was happening. And to really highlight that, here's an individual slice. This is a OCT fluorescence cross-section. The fluorescence is pseudo-colored here in this ring, with yellow being brightest. We can see here in this area where it's relatively inflamed in a single cross-section. These are co-registered based on fiducials such as venules and so forth. Here's a plaque burden of 12.5%. 4 weeks later, the plaque has grown, as you can see here, to a plaque burden now of 34%. But look at where it's grown, right in the area where it's inflamed. So really on a single cross-section, we are able to now show that this is actually happening, that it's linked to the inflammation status. A single baseline measure does a very good job to predict the change in percent atheroma volume across this lesion. And even after adjustment for the baseline plaque burdens and MLDs, there are reasonable predictive values from this. So this is really one of the first concepts in coronary-sized arteries that inflammation itself is a predictor of plaque progression. And I just leave that as a thought to just frame around the recent PREVENT trial, which did a really remarkable job to demonstrate the use of detecting high-risk non-culprit plaques using structural-based imaging based on IVUS or OCT or spectroscopy. If we add fluorescence and inflammation into this overlay, might we do a better job of understanding those plaques that are even more likely to benefit from preventative therapy? This, of course, is a very provocative trial and needs to be reproduced, but it really demonstrates, I think, what most of us appreciate, that over time, plaques have a risk of progression. That is, of course, our number one cause of death, and we don't have the best way to really understand which ones are going to progress yet. How about for evaluating devices? One of the other things that is really neat about certain devices is that they actually have biological effects. We are mostly plumbers and mechanical drillers and really kind of modify plaques architecturally. But there are actually pretty important biological effects to using devices such as drug-coated stents and drug-coated balloons. So I'm sure everyone remembers the firestorm that evolved in 2018 when a peripheral meta-analysis done by Katsanos suggested that drug-coated balloons for endovascular use were actually associated with increased mortality. It was not a patient-level analysis, but it was enough at 2 years and 5 years to demonstrate almost a doubling of mortality and got the FDA's attention immediately. And so because of that, this led to multiple trials being stopped, and then really the FDA putting a black box label on the use of drug-coated balloons. And so this resulted in a letter and then a market reduction ultimately. And there was recommendations to, at that time to say, even though it had historically been the gold standard and was very effective reducing restenosis and recurrent events in the leg, that it became now a much more controversial issue. So the FDA said we really need to understand this better through, of course, patient-based meta-analyses, through new trials and greater follow-up, but also asked for insights into the mechanism. And it turned out, coincidentally, we'd been doing this study more to understand whether or not drug-coated balloons might serve as plaque stabilizers. But it turned out that there actually had not been much work done in understanding its safety and efficacy. And so this work was really timely, and it basically utilized this standard balloon angioplasty approach in the rabbit, where we now randomized rabbits to either a drug-coated balloon or a regular balloon or sham. And we wanted to look at the effects, what did the drug-coated balloon do uniquely, both architecturally and on inflammation. So serial imaging, baseline IVUS, follow-up IVUS, baseline nerve OCT of inflammation, and 4 weeks later, repeat. And what we found was that DCBs were remarkably plaque stabilizing. The amount of inflammation was markedly suppressed here at the 10-week marks in comparison to standard balloons or sham balloons. And so in addition with that suppression of inflammation, the area between the red and the blue is really the amount of inflammation that's progressed over time. These in parallel were extremely effective at suppressing plaque progression. So actually some trends towards actual plaque regression in a rabbit model. And as opposed to regular balloons, which were more effective than, of course, no balloon, but still not quite anywhere near as effective as an actual coated balloon. So this is really demonstrating that paclitaxel itself into the wall, which of course we know is anti-restenotic, is actually anti-plaque progression and anti-plaque inflammation. This was validated histologically, showing that these plaques had many fewer macrophages, and also their RNA levels of cathepsins were much lower in the DCB arm compared to the other arms. And so it really demonstrated that for the first time, there had been tons done with restenosis, but really very little done with atherosclerosis, which was one of the concerns, is that this was causing some form of progression of atheroma because there were increased cardiovascular events. And so it was reassuring that this is a favorable outcome. And actually, then on top of that, I think it really helped us, think about using DCBs as a preventative PCI therapy. Well, was really focused in on absorbable stents at that time, which of course did not pan out in the U.S., and then reverted to metal stents. But in fact, there really is now multiple trials that are utilizing drug-coated balloons for preventative PCI in the coronaries to prevent high-risk plaque progression, and one was just recently presented. Another fun area, I think, is the use of pharmacotherapy evaluation. One of our biggest reasons that we have had slow numbers of drugs evolve for coronary artery disease is because these are billion-dollar investments from pharma. To take a drug from concept to phase 3 clinical trials is a massive risk for each pharma company. And there have been several negative drugs in the last decade, with HDL risers, as well as other even anti-inflammatory drugs. One of the reasons this happens is because companies do not know how to dose their drugs, whether or not their drugs are hitting their target in the coronary arteries, and what the proper dose is. We can do this in other disease states where it's much easier to get non-invasively imaging done, but in the coronaries it's harder. So an intracoronary fluorescence approach may have this ability to understand if drugs are really having a putative anti-inflammatory effect in coronary-sized vessels. So we became interested in understanding the role of GLP-1 receptor agonists, which of course are just absolutely exploding with use across our country and worldwide. And this is really because of randomized controlled trials very compellingly demonstrating that MACE is reduced in patients with diabetes or obesity, and that there are actually systemic blood markers of inflammation, HSCRP, that are also reduced in these patients. So it is a direct anti-inflammatory effect as measured in the blood. And then there's several studies mechanistically looking at mice atheroma showing that there are plaque stabilizing effects. But One of the unknown, a couple of the unknowns is one is we don't really understand mechanisms on coronary size plaques because we typically don't study those in large animals. These have really not been studied. And more importantly, I think we started to wonder, could these actually be useful as a direct anti-CAD agent, even if there was not a background of diabetes or obesity? Because right now, this is where we limit our GLP-1s. And so we were interested in applying this methodology, the same study approach with the same animal serial imaging at baseline. This time, though, we randomized animals to a liraglutide infusion for 4 weeks. So these are subcutaneously placed osmotic mini pumps, and they will just give a continuous level over those 4 weeks. Perform baseline imaging and then follow-up imaging of inflammation and IVUS plaque burden. And this is under review right now, unpublished. But basically what we found was very encouraging that even in non-diabetic, non-obese subjects, there was a reduction in plaque burden and in plaque inflammation as measured by 2D fluorescence imaging. This work is being fortified with a clinical study as well as in vitro work. But on the pathology, where the fluorescence for the cathepsin activity, inflammation centers in orange, we saw similar effects on the actual pathology, that there was less intensity of the cathepsin imaging agent that was depositing in these plaques. The catheter is detecting this fluorescence red signal. And this corresponded with reductions in cathepsin S, the protease that we were imaging, as well as fewer macrophages. So it raises this concept that really we might have GLP-1s for all, possibly. This, of course, needs to be tested. But could this actually be another therapeutic option for patients, even if they don't have diabetes or obesity, which is still half our country? And the last application that I just want to show before the clinical trials is this concept that we've been talking a lot about the use of fluorescence for kind of high-risk plaque detection and for prediction. But there are also opportunities to start to use this at point of care and PCI guidance. And that certainly is a much more understandable short-term application that I think many interventionalists will say, well, I recognize the value of this technology almost right away, as they start to see something that might help them do PCI better. So we've been interested in understanding whether or not this might be a way to better understand geographic miss or stent edge dissection, specifically focused on IVUS. And the reason we're focusing on IVUS is still the worldwide used dominant modality. It's still about 90% of intracoronary imaging cases. And IVUS is relatively low resolution, of course, as we know, compared to OCT. So mechanical complications such as stent edge dissection or geographic miss, much harder to detect by standalone IVUS. And geographic miss does occur. This is something where we might balloon an area that's not fully covered by the drug-eluting stent, or we might actually miss a part of the plaque that should have been covered in the first place, especially if people are not using pre-stenting imaging. If they're only using it post-stenting, that might happen. And then stent edge dissection, which was recently shown from the Illumium investigators, proximal stent edge dissection is a really big predictor of stent thrombosis and events. And it's much more likely to occur in areas, of course, where there's residual plaque that has been injured or just missed. Standalone IVUS it's challenging for standalone IVUS to really detect stent edge dissection and also to rapidly detect geographic miss. And the reason, and I just put this schematic here for showing what we're talking about, is really at the edges of the stent is where we can get tears from the metal going into plaques or into the wall, and that's an edge dissection. And then there's areas of plaque that may not be covered. They might have been ballooned, and maybe the stent didn't cover it, maybe there was movement, and we have miss. And so these things are sometimes hard because if you look on an IVUS long view, which is the first thing we get out of the cath lab, we get the long view pullback. Even though we can usually see the stent here, for example, kind of hard to see. Maybe there's plaque here, maybe there's dissection here, but it's really not easy to see on a long view. So what do? We're usually now scrolling through the axial images, just looking at them as fast as we can. As an interventional cardiologist who does this work, certainly by the end of a longer case, we are usually flying through those images. The amount of time we spent is 1/100th of that of a core lab that is trying to pick up stent edge dissections. So we're going to miss things. So we thought that maybe we could leverage fluorescence to better understand geographic miss and stent dissection. And this is just an example of how we got there. One of the imaging agents that we decided to explore was an imaging agent called indocyanine green ICG. This drug has been FDA approved for near-infrared fluorescence imaging of the eye for 50 years. It's used every day outpatient for retinal angiography. And it measures the angiogram in the eye and also measures vascular leak. So we said vascular leak, that's perfect for edge dissection and geographic miss. And so we said, we actually did this in rabbits and demonstrated for the first time that ICG can leak and bind in lipids and macrophage-rich areas, and did a small clinical study of 5 patients, also showing the same things were true, that in areas of leakage, ICG will bind the subintimal space for several targets. And so we said, okay, let's do this in a rabbit model, and let's create 2 plaques, one in each iliac, one where we optimally cover it with a stent, and the other one where we markedly intentionally miss. And let's see now what the IVUS looks like, and then see what fluorescence from ICG leaking into the non-covered areas, is that actually something that we can see quickly and easily. So we now, using our fluorescence IVUS system, not our fluorescence OCT system, we performed imaging, and I would say this is one that was, there's a fair amount of geographic miss intentionally here. It's on this side. You can see the plaque right here. We only stented the bottom half of it. And I would say if you look at the 2D long view, you'll see the stent here, and you'll say, well, is there actually any injury? Hard to know on the long view. Here's what the ICG overlay allows us to see. This is now here where it's very clear that at the edge of the stent, which of course is really well demarcated by IVUS, you can see here this hyper-intense area showing ICG has deposited just north of the stent. This is exactly where edge dissections occur, geographic miss occurs, and you don't have to be an imaging expert to know that there might be a problem at the edge of this stent. Now it makes sense to go back and look at your IVUS images with intent to specifically look for dissections and problems that might need further treatment, other angioplasties or stent coverage. So this is a concept that we're just still refining. The nice thing about it uses a drug that's already approved, FDA, and it's super fast. It has a very short half-life, so you can inject it as you're doing your post-dilatation, and then when you do your final IVUS run, you're able to actually get this information. So this might be in another application point of care. And so as our last part, I'll talk about where we are now clinically with this work in fluorescence and OCT. The way that we recognize that we have been talking a lot about molecular imaging, to really do this in patients, we needed to do clinical work. And this has happened in 2 stages. One was really testing of the fluorescence OCT catheter without an imaging agent to measure autofluorescence at 630 nanometers. That turns out to be a very unique area. It hadn't really been established what autofluorescence is in the near-infrared short NIR. There's lots of papers for 40 years about visible light autofluorescence. This was the safest way for us to test the catheter efficacy and safety without having the complexity of having a second part, which is an imaging agent, which is going to happen in the next stage. What we did is actually now almost 8 years old, is actually tested a home-built combined fluorescence OCT system that was built by my partner Gary Turney, who has really developed OCT for the world in the coronaries. He had an IDE. We're probably the only center in the academic center in the world that actually develops hardware for intracoronary imaging from an academic IDE. Everything is usually done out of industry. So he has a tremendous operation and an incredible engineering group. And so we basically worked together to get this FDA approved on an IDE and did 12 patients. And what we found, this is a very similar pullback test to what you see. The OCT quality now, of course, is superior in this final clinical system. The ring is the OCT fluorescence, and it's autofluorescence. That means there was no imaging agent. This is just the intrinsic autofluorescence in the NIR of these plaques. Well, that was really remarkable, and you can see that there's really spot areas. It's not everywhere across this pullback, but certain areas, and this was felt to be consistent with an OCT TICFA area. This was a calcified zone. We were seeing hot spots of NIR fluorescence. This data was actually acquired before we had a clear sense biologically of actually what that fluorescence signal means. There was some histological data suggesting that this concept of near-infrared autofluorescence, NIRAF, was in necrotic cores, but we didn't really know the molecular components. So 2 papers really happened after this that elucidated this. When we first analyzed all this clinical data, what we found is, and there were about 40 plaques, is that as the plaques became more complex and became more high risk, such as TICFAs and even a ruptured plaque, that the amount of NIRAF was going up. So this is at least correlating with a high-risk plaque phenotype. What does it mean exactly is still under investigation, but 2 papers really came out for that. One was based on a concept of intraplaque hemorrhage. Karl-Heinz Peter in Australia, this group basically co-localized near-infrared autofluorescence with bilirubin in intraplaque hemorrhage, suggesting that this is really a source of near-infrared autofluorescence. We thought that was true, but when we looked at our own individual pathology, we also thought there might be a second component to this, or a different, maybe even dominant component. And when we started staining for a form of oxidative phospholipids called ceroid, this is really in many tissues an aging pigment, but in pathology, this is a marker of oxidative stress. Sudan black stains for this oxidative lipid. This was actually correlating quite nicely with NIRAF as well. And so we found that, yes, we could see in intraplaque hemorrhage areas here, this glycophorin A, there's co-localization, but there's also very similar co-localization with ceroid. So ceroid is this marker that has demonstrated prior oxidative stress. In itself, it actually may be pathological. We are working on that right now to figure this out. But these are the 2 components contributing to those, and both are high-risk plaque features. And so now this has really set the foundation for a clinical trial, which is happening in Japan and the US. We worked with a company, Canon Medical, to now develop a commercial fluorescence OCT catheter. We've done 4 patients at MGH. I'll show you a picture in just a minute of their system. Our interest in this is to understand, does this NIRAF autofluorescence signal predict plaque progression in patients? To that, we're going to do serial CT on these plaques that have had NIRAF imaging to understand, does the NIRAF signal predict plaque progression, or on a patient level predict overall progression? And so this is happening now and is scheduled to enroll 20 stable patients and 20 ACS patients. This is their system now, so looking very commercial. This is a pullback 40 millimeters per second, very rapid, excellent high quality OCT. You'll see the very focal areas of fluorescence here. This is actually the guide, but there's spots along the way that show spot fluorescence. And so this is now happening, and our colleagues in Japan have already completed their 30-patient study and are doing an extended follow-up. So very straightforward in terms of doing it. So our conclusions from this part is that this is a new approach to image plaque pathobiology. It's coming. It's now first in human. The second step is going to be actually combining this with an imaging agent for inflammation. That's happening next year. The application so far on the preclinical side is that we can predict plaque progression beyond structural measures, that we can look at device anti-inflammatory effects as well as drug anti-inflammatory effects, and that we are now having some emerging applications for PCI guidance. The 2 active clinical trials, one I just showed you, is understanding the role of NIRAF. That's happening now. Next year, through an NIH-funded trial, we're going to combine this fluorescence catheter with an imaging agent that specifically reports on cathepsin protease activity to do dedicated first-in-human fluorescence imaging of inflammation. And our overall conclusion is that by doing this, by better understanding the biology of coronary disease, we're going to do a better job to personally phenotype patients, have them better understand their risk, optimize their pharmacotherapy based on their inflammatory status. And so before I go on to part 2, maybe it's just a time I am happy to take questions. This is a lot of work on fluorescence. Maybe this is a good moment. Or you want me to finish? Okay, we'll go to the end. All right, so we're going to shift gears a little bit and go into part 2, which is really this other application of trying to use advanced imaging, but for a very different purpose. It's to really guide complex PCI and chronic total occlusion PCI. So as we know very well now, the role of coronary CTA is really revolutionizing our care for screening and prognosis of patients with coronary artery disease. And this has dramatically increased, and it's going to continue to increase, really in part driven by the ischemia trial, but also I think our general recognition that our predictive values and our specificity is so much greater with CT that allows us to do a better job of triaging patients for cath almost right away. We're now seeing an enrichment of patients who come to the cath lab with known coronary disease. We're not guessing with false positive stress testing. We have true optimization of our cath labs is really happening from CT. And there's also this whole world of CT guidance for PCI that is also happening. As you know, you have a very active world-class CTO program here, led by Dr. Alpesh Shah. It is really now, I think, convincingly demonstrated that we can improve quality of life. I think it's an extension to say that we're improving prognosis with CTO PCI. Observational trials suggest that, but randomized trials do not. There are many reasons for that, but I don't think we need to go there. I think that we wouldn't ask an orthopedic surgeon to tell us that fixing a knee is going to improve mortality. We do probably think that in 20 years, if a patient isn't moving, that their outcomes are going to be poorer, but we're not doing 20-year studies of those patients. We're not holding them to that bar. Improving quality of life is really important and is our primary metric for treating stable coronary disease patients. So we have a randomized trial called the EuroCTO study that was published by Charles Warner, really demonstrating that this is effective in reducing angina and dyspnea, probably being the number one symptom of CTOs. In addition, it leads to lower target vascular revascularization. This is a limited endpoint because it is subjective. I think many patients who have even atypical symptoms will get referred. So I don't rely on this. I really focus on the symptom reduction burden. Now, because CTO PCI has risk, this is really now recognized that this should be the primary indication for CTO PCI is ischemic symptom relief, and it really should be on optimal medical therapy. I prescribe the most ranolazine in New England because my goal is to defend patients from unnecessary procedures. And usually by now, we're seeing most of our patients referred on at least 2 anti-anginals. Every now and then it's rare that there are 1. But I still will layer on number 3 and 4 before doing a post-CABG circumflex CTO PCI. And about 10-15% of those patients will become very comfortable with their lives, and they're happy to move forward with just medical therapy. And so that's really on us as a community. These are some side notes, just comments related to CTO PCI. Because we know it carries risk, specific training is required, and these consensus papers are really great to look at the role of CTO PCI and its perspective. But one of the things about risk is that maybe we can start to do incorporate some new approaches to improve our efficacy and improve our safety. And this is where our interest in utilizing real-time CT became of interest. We know that CT now does a great job to actually predict complexity of CTOs. It does as well as the JCTO score, does better than angiography. What do we know about it in CTOs? Well, one of the things that we know is when we have a gap segment where there's no contrast, we do not know much about the course of the artery, especially in long CTOs. But CT can see the wall, it can see the soft tissue, it can see the calcium much more sensitively, and we can now get an actual course of vessels. We can also clarify ambiguity, a really important part, and also that also involves sometimes with grafts and graft touchdowns and tenting of grafts and stent jailing of distal touchdowns. About 8 years ago, we explored a CT fusion protocol offered by Siemens, which I know is here, and that's available in probably a quarter of the country, and recognized that it had been used for kind of structural-based guidance, but not had really been used for CT guidance. So about 10 years ago, we worked on this and demonstrated in 12 patients their ability to do real-time CT fusion, and showed it had prediction for understanding complexities of antegrade dissection reentry and even some ambiguities with retrograde work. And this was now subsequently followed by a randomized controlled trial showing the value of CT in guiding CTO PCI with an absolute increase in success rates of 10% and reduced perforations in PPI, so signals for efficacy and safety. This is pre-procedural, not even using it real time. So there's some real value emerging for CT in this situation. How do we do it? As you have seen here, we start with any coronary CT angiogram. It's vendor agnostic. It's incorporated into the cath lab system. My post-college clinical research coordinator does the first pass. It's pretty straightforward, 10 minutes, and then I will look at it for about 2 to 5 minutes to understand if it's a reasonable segmentation. Then in the cath lab, we'll obtain 2 angiograms, typically 45 degrees apart. There will be a 3D registration that occurs to synchronize the 3D CD data set with the 2D kind of angiographic data set. That registration is seamless. It's a button click. Then the CT can be toggled on and off as an overlay. It doesn't rotate, doesn't beat with the heart. It's not active dynamic registration, but it can certainly be rotated to the different angles. It does a good job to move, but then fine tuning is required as you move from angle to angle. I'm going to show this for a case that we recently utilized this in a patient who had a very complex post-CABG total occlusion from a vein graft to a diagonal. It was now a 25-year-old, almost 30-year-old, 30-year-old CABG, so very calcified and occluded. He had undergone other revascularization and remained significantly impaired with an occluded D1 target, and you'll see that here. This is one of our most concerning targets. It's a lima supplying a very large diagonal through a somewhat tortuous epicardial vessel. As those who are following the CTO world will know that this is one of the most dangerous parts is to consider epicardial work. And so one of the approaches that we try, we have a big debate about, do we consider even just doing a partial investment antegrade, coming back and avoiding epicardials. And that in general is our approach for most complex cases, but there are some times where it's not possible to go antegrade. The more guidance one has in these cases, the better, and I'll show that in this case. So this patient had a very blunt, somewhat ambiguous origin. There's an LAD coming up here and a diagonal coming here. Can't tell exactly. It's a large vessel, and it is actually very calcified on CT. And so he had clinical indications to move forward. He had class 3 angina. He had been hospitalized for unstable angina several times. And so we said, well, can we get at this antegrade? We'd like to avoid this, fairly tortuous epicardial. And so we tried, and here's our CT guidance. This is the LAD coming up and over. This is the diagonal branch. Now, taking a very stiff wire into blind space here, very dangerous. Not something that we want to do without guidance. This is about a 25, 30 millimeter CTO segment. And we had much more confidence to even start this case and start to go antegrade when we had this segmentation overlaid, right? Like, how do I know that I'm not deviating into something else? Is the LAD here? I can't tell, but I can definitely get a sense of that from CT overlay. This is not precise on a 100 micron level resolution, but on a millimeter resolution level, it's reasonable. So we started to go antegrade, and we stuck with jacketed wires initially. We just didn't still have the confidence to push forward. It wasn't fully resolved here. So we decided to go retrograde with the standard precautions that we always have a perforation kit. We have coils. We've talked about it, counseled the patients multiple times. And fortunately, this was a reasonable one to cross. And we said, wow, okay, this is great. We're going to now work on our distal cap, get a reverse cart going, and we should be all set. So here's the distal target. We brought a microcatheter up here to the distal cap. Here's our proximal wire and our guide. And we're like, okay, we're just going to connect right up here. This looks perfect, right? We're going to start retrograde knuckling, and we should be able to meet this antegrade target and do our work. Well, when we stuck the wire up here, and I didn't have this show, but the wire kept going, and it kept going, and it kept going, and kept going. And I said, okay, this is a Pilot 200, and we don't use stiff wires that are non-jacketed. And I said, okay, well, that's really alarming. Where am I? And it took me a while to realize, I was actually going through the graft, touchdown, and this architecture was extremely distorted. This is actually, the native artery comes up like this. It's actually tented here. Now, I came to that conclusion much faster because I had the real-time CT, and in the other view, I didn't have it stored here. But that hook exists also in that cranial view. And so now I went back to this view, and I said, okay, knowing this, I took a wire and we actually redirected the wire this way. That would have been really hard for me to do. So we redirected north and actually started to knuckle this way, and we're able to drive this now around the hook here and follow that with a microcatheter. I have to say, seeing that course and that distortion, it was really great to have the CT overlay to let me know. So I got to this point here and I stalled, and I said, all right, well, what can I do to kind of get going? And now we came in antegrade, and I didn't show that part here, but now we came in antegrade with a very stiff wire. We took an Estado 20 because that was the only wire that would penetrate. And now we could aim, and it went in a very straight line towards this target guided by CT. All of this really was now much more de-stressed, de-risked, because we had that guidance there for us. Ultimately able now to form a knuckle that is confluent with the retrograde system, perform externalization of this, perform retrograde wiring of the antegrade guideliner here. Then performed a tip-in, because we try not to fully externalize wires on epicardials, and that was successful, and then ultimately completed a stenting procedure, and that went great, and he clinically did well. This is really just one of my more favorite examples of the role of vessel ambiguity resolution by using real-time guidance. And so, to kind of conclude on this part, this is really a valuable technique for understanding difficult CTOs. It provides a natural roadmap. We like it for resolving ambiguity, for understanding long dissection planes, even antegrade, to make sure that we're staying in the main course, and to help us also not miss severe amounts of calcium in the vessel as we're dissecting. With that, I will conclude. We have an extensive number of collaborators to allow this work to really happen on the molecular imaging side. It's a project that is shared between radiologists, chemists, vascular biologists. All the fellows do the really hard work by doing the experimental work, and I'm blessed to have great collaborators and funding sources. So thanks so much for all of your attention.
All right. So I felt like that was 2 grand rounds in one. So thank you very much. But not only I want to first congratulate your team and all the work you guys have done, but in the interest of time, I actually want to open up the questions to the audience first, because I'm sure between our imaging colleagues and PCI colleagues, there will be a lot of interest into this topic. So, Dr. Patel.
Thank you so much for that talk. So going back to the first part where you talked about the fluorescence imaging, you showed some examples, very cool looking pictures, where we saw some non-obstructive disease with some lighting up, suggestive of this protease activity, it sounded like. My question is, are these markers specific to a type of inflammatory marker like protease activity? And then what's the correlation between some of our systemic biomarkers of residual inflammatory risk, like a high sensitivity CRP, and then those local markers of inflammation? Are we actually capturing those patients who may have that residual inflammatory risk?
Great. Yep. Problem with HSCRP is the drivers of HSCRP. If I have a huge peripheral plaque or a carotid plaque, how do I know if HSCRP is actually, so HSCRP is being produced by the liver. I don't know if that's being driven by an atheroma that's driving the liver to produce that, or vice versa. That mechanism to me is not fully clear. But we have this very diffuse atheroma signal. So I don't think that we can say a single measure of hsCRP means you have plaque. Of course, our first gateway is now CT to understand that.
Dr. Laurie, go ahead.
Gerald Laurie, I'm a cardiac surgeon here. Congratulations on your outstanding work. As we know, the role of inflammation in this disease has been very well established, and you've been doing some remarkable work in further refining this understanding. On the other hand, clinical application of drugs directed specifically to block inflammation haven't been very successful. So I'm wondering whether your work might also have the added benefit of either identifying a mechanism or a new target for either existing drugs, or possibly pointing towards a direction for the development of new drugs that will be more effective in subduing this inflammation, which is obviously such a central process. Because obviously the desire is to get something you can give the patient other than a whole series of angioplasties chasing these areas of inflammation around their coronary arteries.
It's a wonderful question. Thank you for the comments. I didn't show this for the sake of time, but colchicine, had been recently FDA approved for the treatment of coronary disease based on its anti-inflammatory status. Very recently, of course, people are probably aware of the really remarkable data just presented at AHA that found colchicine to be neutral in a 2x2 trial for post-MI patients, and in terms of affecting outcomes. So kind of contradicting the work that had happened in 2 prior clinical trials. And so while I was initially disappointed in that, because I thought, well, we have a therapeutic, colchicine, we were thinking about it, maybe patients here are starting to actually be prescribed it. We now have this neutral trial. This impressed on me even further the importance of actually defining inflammation as part of someone's disease process. Why wouldn't I want to treat patients who actually have coronary inflammation with an anti-inflammatory? So that refinement will occur, I think, based on the ability to image inflammation. And ideally, if we're doing this post-PCI at the end of primary PCIs and so forth, we'll have the ability to image the non-culprits and get that. But it also sets the foundation for other drugs, and there are other molecular imaging agents that might be more specifically targeted to, for example, IL-6, which is being tested. These are all possible to design. We do need to do that. That's a big area for pharmacotherapeutics, are designing reporter imaging agents along with the testing of the drug. This happens in cancer very often by taking the drug and labeling it with a PET radiotracer, injecting into patients to look at the distribution. This is starting to happen for the field of fluorescence as well in these invasive types of places such as the coronaries.
Okay, well, I think we'll conclude our grand rounds today. Thank you all for your attendance. And again, thank you, Dr. Jaffer, for visiting us.